Okay, we will continue back our session. Next speaker, we have Mr. Yahya Muhammad Arifin with us. He is Senior Consultant Breast and Endocrine Surgeon from University Technology Mara. His topic is lobular carcinoma in situ and lobular carcinoma current management updates. Mr. Yahya, welcome.
Okay, Assalamualaikum and good morning. Thank you, organizer, for organizing this. I'm going to talk about lobular carcinoma in situ, LCIS, and invasive lobular carcinoma, ILC, the current management update. Can you hear me? Shall I continue? Okay.
Yes, Mr. Yahya, please go on.
Okay, this will be my outline. I think I'm going to spend about 20 minutes talking about lobular carcinoma in situ, LCIS. We'll touch on the definition, clinical significance, and treatment. And for the last 20 minutes, I will talk about invasive lobular carcinoma, the epidemiology, how ILC differ from IDC, and we look at the treatment option for ILC. Okay, what is lobular carcinoma in situ, LCIS? LCIS is a neoplasia arising from the endothelial lining of the lobule. Okay, to be specific, at the terminal duct lobular unit. So you have breast here, right? This is the functional unit of the breast. So we have a duct and we have a terminal duct which connected to the lobule. And the lobule consists of many acini. So this LCIS arising from this area. If you look at this is normal breast tissue. This is lobule. Can you see my cursor? Can, this is lobule, and this is lobule. So this lobule, inside this lobule, we can see acini. This is the acini, okay, lined by cells. And at the center of the acini, you can see the lumen. Okay, this is the normal breast, normal lobule. Yeah? So how this LCIs look like under the microscope? You see, this is lobule and this is the acini, and you can see that the acini is filled up with cells. Okay, although the cells seems to be uniform, and can you see the lumen in the acini? No, you cannot see the lumen. All the lobule has been filled up with the cells. So this is how this LCIS differ from the normal breast tissue. Okay, you have to know a few terminology when we deal with LCIS. LCIS can have different variant. We have a classic LCIS. That is the most common type of LCIS. We also have pleomorphic LCIS. You can see the photo in the middle here. You can see that more cells and the cells look larger. And the nucleoli shows some variations in the shape and the size. So you can see that there is a pleomorphism in the nuclei of the cells. So these are pleomorphic LCIS. On the right side, you can see that the cell is more compared to classic and pleomorphic. And you can see and also when the cell is more, you can see the central necrosis also in the alveoli. So this is the the LCIS with necrosis. So why you need to know this? Because the management will be different. Another terminology you have to know is a lobular neoplasia. What is lobular neoplasia? It's a neoplasia that develop in the lobule, huh? And it consists of LCIS and atypical lobular hyperplasia (ALH). How do these two differ? You look at this LCIS on the left side, all the acini is filled up with cells. But if you look at this is a single acini. Single acini, not all the acini being replaced uh, by the cells. We can see that some area the proliferation is not so much as the other area. So when this proliferation is less than 50%, we call it ALH. If it is more than that, it is LCIS. Okay, how common is LCIS? The true incidence is not known because lacking of clinical and mammographic sign. How we this LCIS is detected uh, from biopsy. Okay, and if you look at the number of biopsy that has been done, 0.5% of the biopsy for LCIS, biopsy for clinical abnormalities, and 2.3% of biopsy done for mammogram abnormalities are LCIS. Whereas for biopsy done for mammogram abnormalities classified as malignancy, we can find 9.8% of this biopsy has LCIS. The mean age for LCI is between 44 and 46 years, and majority of the patients are premenopausal women. So what about the clinical features and imaging of LCIS? Is there any specific features and imaging? So what are they? No, there is no. We couldn't find any specific findings in when we examine the patients, and also there is no specific signs in the imaging, whether it is ultrasound or mammogram. So the LCIS basically is an incidental finding. It's found in the biopsy done for other reason. But in certain cases, rare cases, pleomorphic or florid LCIS may show microcalcifications or architectural distortion in mammogram. What are the clinical significance of LCIS? Is it cancer? If we compare with DCIS, we know that DCIS is a cancer, is considered as a cancer, early cancer, right? But what about LCIS? Is it cancer? No, it is not. It's not considered as a cancer. Look at the NCCN guideline, the recent guideline, it has been removed from the guideline, so it is not considered as a cancer. Is it a risk indicator, meaning that is this LCIS can indicate that the patient will develop invasive cancer in the future? Yes, that's what the LCIS is all about. It's actually a risk indicator. What about cancer precursor? Cancer precursor means LCI by itself can progress and can turn into invasive cancer. Could be, it could be, and we will look into that in a minute. Okay, this is the population data from US involving almost 20,000 women which has been diagnosed with LCIS. And this woman we follow up So what the findings? After 10 years, this woman, 11.3% of them uh, was found to develop invasive cancer. Then after 20 years, 19.5% of them developed invasive cancer. And the incidence of increase with increasing age, depending on when you follow up the patient. If it is less than 40 years, the the incidence 6.9%. If it is more than 70 years old, you follow up the patients, you're going to have 13.9% after 10 years follow up. And another interesting fact about this is that majority of this patient that who develop invasive cancer, majority of the cancer are of ductal histology, invasive ductal carcinoma, 42%. ILC develop in 20%, and mixed ductal endometrial in 30.5%, and DCIS developed in 21%. And also, it's noted that the invasive cancer, they do not confine to the original site of the LCIS. It can be both, it can involve both breasts. And if it is at the same breast, it's not necessarily at the site of the LCIS. And the invasive cancer also shows some is favorable cancer profile. It is early stage, low to intermediate grade, and hormone receptor positive. The breast cancer specific survival tend to be excellent. 98.9% of the patients still survive after 10 years, and 96.3% survive after 20 years. Okay, the concept of LCIS as a cancer precursor actually is not a new concept. When this LCIS first described in 1941 by the Food and Stewart, they described this LCIS as early cancer. Okay, and mastectomy was an option, treatment option at that time. But when we have more data in 1970s and 1980s, the era of breast conserving surgery, if you remember, it was noted that the rate of invasive cancer, the conversion to invasive cancer was low, and most of these invasive cancer were non-lobular histology, and they are not occur at the original site of LCIS. And because of this, the concept of LCIS as cancer precursor was abandoned. Until recently, I think last few years, when we have data on genetic, which shows that LCIS has same genetic aberration as adjacent cancer. When they look at the genetic of the LCIS and then compare it with the invasive cancer adjacent to them to this LCIS, they found that the mutation is exactly similar. Okay, so from this, they postulate that LCIS is not only a risk predictor, but also a non-obligatory precursor, meaning that some of these LCIS will progress and turn into invasive cancer. So now there is ongoing genetic study that try to look at the better understanding on natural history of LCIS and cancer progression, and also to try to look at to determine which LCIS will progress to cancer. Okay, as a surgeon, okay, when we have this HPE report came back as LCIS, what you going to do? Whether you need to excise or you just leave it, follow up the patient. Okay, all right. There are a few factors to consider. You have to look at whether there is any radiological pathological discordance. Histology says that it is LCIS. Then you go back at the patient, see whether patient has any strong family history with the whether you can feel any lump in the on physical examination, because you don't expect that if it is classic LCIS. Okay, or probably you look at the mammogram if you can find any suspicious lesions seen in the mammogram. If there is any radiological pathological discordance, then you might consider for excision. Another thing is whether there is any other high risk lesion, proliferative lesions present at the same time. Okay, if there is any proliferative lesion present, you might consider excision of this LCIS. And the thing is that the variant, whether you look back at the pathology, whether it is reported as pleomorphic or we can see any necrosis in the histology, and for that you need to excise the lesion. Okay, when you after you excise, the lesions, what will be the margin? Okay, this is uh, in DCIS, for example, right? You have an issue of margin. You need to get a 2 millimeter margin, and after excision, do you need to give radiotherapy as what you do for the DCIS? No data on what is the optimal distance between the tumor and the margin. Okay, so what does it mean? It means that as long as you can get a free margin, no matter whether it is 1 millimeter, 2 millimeter, or whatever, is good enough. Should you give radiotherapy? No data to support the benefit of radiotherapy after excision, so you don't have to give radiotherapy. Okay, we know that LCIS is, the patient is going to develop invasive cancer in the future. It is more than the average woman. So you need to have some form of risk reduction measures. So what we can do, you can see this patient every 6 to 12 months, get the history and examine the vision, and mammogram every year. Okay, and if you have a tomosynthesis, you can consider tomosynthesis, but this mammogram should not be done earlier than patient 30 years old of age. And you may consider MRI breast if the patient has other high risk factor. Okay. Is chemo prevention recommended in LCIS? Yes. You should advise the patients for chemo prevention. It's premenopausal, you can give tamoxifen for 5 years. And postmenopausal, you have option. You can use anastrozole, exemestane, raloxifene, or tamoxifen. But FDA only approved the raloxifene and tamoxifen for this use. Okay, in conclusion, LCIS is an incidental finding detected from biopsy performed for other reason. It cannot be detected by physical examination and is hardly seen in imaging. It's a risk predictor, meaning that presence of LCIS indicates that the patient is at higher risk of developing cancer in the future. It may be a cancer precursor. By itself, it will progress into invasive cancer. Not all LCIS require excision. Excision or re-excision is indicated when there is discordance between radiological and histological findings, presence of other high-risk lesions, or presence of an aggressive variant. Okay, now we come to the ILC. I have another 10 minutes. Okay. Invasive lobular cancer, carcinoma, contribute 8 to 10% of all invasive breast cancer. and majority of the patients diagnosed at the age of 55 years or older. So this is an older age disease. Okay, we familiar with IDC, invasive ductal carcinoma. So what I'm going to do, I'm going to discuss this ILC and compare it with IDC. I think by that, I think you can have better understanding. We're going to look at the histology, clinical features, and imaging. Okay, this is the difference with IDC and ILC. IDC on the left side, you can see that the cells proliferate and the cells they stuck to each other. Okay, they form a cords and nest. Okay, and uh, and imagine if this involve a larger area. Okay, and this lesion can be palpable. Okay, and also can be seen in the mammogram. You can see the architectural distortion, all that. But in ILC, the cell is actually aggressive cell. On the ILC on the right side, the cell is aggressive cell. The cells proliferate, but they do not stick to each other. Rather, they diffuse into the the surrounding tissue in a single file or Indian file pattern. Okay, and they do not form a clump of cells, and that's why you hardly feel these lesions on palpations, and you hardly see this in the mammogram. Okay, ILC, they tend to have favoring cancer profile. Most of them are ER positive. Most of them are HER2 negative, and they are low grade tumor and low probability index. And in the immunohistochemistry, uh, this is the hallmark feature of ILC. When the pathologists they couldn't differentiate whether it is IDC or ILC, they can do this staining. Where in ILC, majority of the ILC they do not have this E-cadherin protein. Okay. Okay. And they do not present with a distinct lump, but rather probably, or you probably couldn't feel anything, but all just tissue, or just tissue thickening. And ILC, they tend to be bilateral in comparison to IDC. They tend to be bilateral, and they tend to be multifocal and multicentric. Multifocal means different focals at the same quadrant, and multicentric uh, multiple focals at different quadrant. This ILC is, as I said just now, it is hardly seen in the mammogram. Tomosynthesis tend to improve the mammogram accuracy. Ultrasound is better than mammogram, and MRI is reported to be better than mammogram and ultrasound. Even though the mammogram has a limitation, but it's still the gold standard for screening and diagnosis for ILC. I think because of we're already familiar with the mammogram, the evidence has been there for decades, right? So we still stick to the mammogram. How we treat this ILC? Should we treat ILC as we treat IDC? Okay, the principle of treatment for ILCs in general, it's same as how we treat the IDC. Okay, and if you look at the guideline, there is no specific guideline for the treatment for ILC. Okay, I think this is my last slide. Uh, Surgery to the breast. Is there any role of breast conserving surgery for ILC? Because we have an issue of diffuse infiltration of the tumor, right? So can you do, and also multicentricity, can we do breast conserving surgery? Yes, you still can do. No, no, the principle is the same. How big is the lesion in comparison with the size of the breast, and whether there is any other lesions in the same breast. You know, if you fulfill the criteria, you still can do white local excision. What about the margin? You know that the IDC, you need to get a certain margin, right? Uh, Margin for ILC is still the same. There's no ink on tumor. As long as there's no ink on tumor, you are okay. This is same as IDC. Surgery to the axilla, can you do sentinel node biopsy? Yes, you can do. Huh? It's an option. If there is no clinically, there is no lymph nodes, you can do sentinel node biopsy. Chemotherapy, yes, probably oncologists will give chemotherapy, but they tend to not very responsive to chemotherapy. This is because of, remember that the proliferative index is low. It is not that aggressive, so-called tumor. So that's why it is not that responsive to chemotherapy. Radiotherapy, okay, radiotherapy, yes, you have, uh, after white local excision, you have to give radiotherapy. Hormonal therapy, better response compared to chemotherapy because majority of the LCIS, they are hormone positive. They tend to respond better with hormonal therapy. Neoadjuvant, can you do neoadjuvant for any LCIS? Yes, it's up to you. If you want to do neoadjuvant, you can do neoadjuvant, but better you use hormones, rather anti-hormone therapy rather than chemotherapy. Okay, in conclusions, LCIS is a cancer with diffuse proliferative pattern and is often multifocal and bilateral. It has no distinct physical findings and imaging signs. It possesses favorable cancer profiles, hormone receptor positive, low-grade tumor, and lower proliferative index. The principle of treatment is same as IDC, involve multimodality treatment. Less invasive surgery such as white local excision and sentinel nodes is not contraindicated. A majority shows good response to hormonal therapy but less responsive to chemotherapy. Okay, that's all from me. Thank you.
Mr. Yahya, you can go back to Amy to review the question from the audience.
Okay. Okay, the question here for the different types of LCIS with different behavior, are they known to coexist? Huh. Uh, I don't have information for this, but why not? Uh, if the classic and probably they can have some focus of necrosis as well. So that's why it depends on how you do the biopsy lah, I think. If you whether you use the needle biopsy or whether you excision biopsy. Excision biopsy is always better than needle biopsy. Uh, uh, if you use a needle biopsy, for example, you tend to miss all the focus of aggressive type, right? That's why you need to look into the radiology and the clinical of the patients. Whether there is any discordance between urological and histological findings. If it is class, for example, it is classic LCIS and a mammogram, they can show something. So you might need to excise the lesions because you're worried that probably you will miss the aggressive types of the tumor, which could be just nearby the one that you biopsy. Okay. For LCIS, that non-pleomorphic but patient has family history of breast cancer, would you observe or excise? Oh, okay. How bad is the family history? Okay. I think you can observe lah. Especially if you don't have any findings in your imaging. If you don't have any findings on imaging and your histology says that it is non-pleomorphic LCIS, I think you should uh, observe the patient. Observe the patient with active surveillance. Active surveillance, okay? And by now, you should consider chemo prevention for this patient, okay? And with that, we hope that we can prevent the patient from getting invasive cancer. And if the patient develop invasive cancer, we can detect early. If we decide for conservative management after diagnosis of classic LCIS, how would be the surveillance? I showed you just now, right? Okay. Anyway, uh, according to the current guidelines, you can monitor the patients by clinical breast examination every 6 to 12 months, a mammogram every year. Okay, that's how you follow up the patient. Assalamualaikum salam. When you mention consider MRI breast for LCIS begin diagnosis, do you mean before excision or after? Uh, no, yeah, before excision or after. No, basically, MRI, you do MRI here because you are not confident with your mammogram. The mammogram is still the gold standard for imaging, whether it is for screening or whether it is for diagnosis. Okay, if you are not happy with the mammogram and also the patient has other risk factor, strong family history, for example, BRCA uh, positive patients, family history of BRCA, then you would consider MRI. Whether it is before excision or after excision, I think that question is a bit off lah. with margin involvement for pleomorphic LCIS with necrosis after resection, do we need re-excision? Some paper treating them as DCIS. Which margin involvement? I don't know what's the question. Depends on what the margin. Uh, yeah, normally when margin, right? When you remove, you excise a lesion, right? You mark the margin, right? Especially when there is a potential that you need to do re-excision. So you mark the lesion, superior, inferior, lateral, medial. Is that the question? Superficial and deep, right? And depends on what the margin, then you have to go in again and you do cavity shaving. Which, okay, is that answering the question? Do we need re-excision? Do we need re-excision? Oh yes. If it is pleo, oh yeah, okay, I understand the question now. Uh, yes, you need to re-excise. It is a pleomorphic LCIS. You need to re-excise. You see, you come to diagnosis by two ways. One, by true cut biopsy, right? And number two, by excision biopsy and the margin involved. There's two ways issue here. Okay, if it is diagnosed by true cut biopsy, then you have to go in again and you do the first time excision biopsy. Okay, but let's say you do excision biopsy for other reason, for DCIS, for invasive cancer, whatever, but the specimen came back as margin involved, but the involvement into just LCIS is pleomorphic, right? And that also you need to remove. Understand? Do we start chemo prevention for all CIS or we can omit for classical type? I think all LCIS, because the data that I've shown, the it is considered as high risk lesions. They are together with apa tu uh, atypical hyperplasia, LCIS, uh, and then the risk more than 1.76, high risk according to Gale model, it fall into that category. Okay, and for that reason, we this LCI should have chemo prevention. Any role of radiotherapy if margin involved post-wide local excision? The same thing we do for DCIS. We have to re-excise the margin. Once the margin clear, then we give radiotherapy. Okay, there's a role of radiotherapy. Can we observe in a patient with a palpable mass and the biopsy report can be observed in a patient with a palpable mass and the biopsy reported as classical SCIS? This one is typical discordance, the radiological histological discordance. This is typical. Histology said classical, and you don't and when you palpate the patient, there's a mass. You should highly suspicious that this is not the ordinary classical ICS. They must have something else. It could be, you know, I would say, I would, you should have by uh, consider seriously of excision of this lesion. Okay.
Thank you very much, Mr. Yahya, for very informative talk about LCIS and lobular carcinoma. We will go to next speaker. Before that, we go back to the launch.